I can take a picture of your lesion.
Yes,
I can send it to the dermatologist, get an answer back pretty quickly, and they can tell me, this is nothing to worry about, or no, we need to take a closer look at that. We might need a biopsy.
This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and my guest is Dr. Matthew Farrell. Matt is an Ohio State primary care physician and a clinical associate professor of family and community medicine. Very often on the podcast, when I've talked with a James specialist in a specific type of cancer, and we talk about symptoms and prevention and screening, our expert will say something along the lines of, if you see this symptom or are experiencing this pain, talk to your primary care physician as soon as possible. They are the first line of defense in the battle against cancer, and Matt will fill us in on how primary care physicians talk to patients about their family's medical history and why this is important, how they help patients understand their cancer risk, get the proper screenings and tests to prevent cancer and or catch it in the earliest stages when it's most treatable. Primary care physicians save lives. Welcome, Matt.
Thank you, Steve.
Boy, we have a lot to cover today because primary care physicians, as I've heard some cancer specialists say, that you have to know every part of the body.
That's right. I like to joke that we know a little about a lot and a lot about a little.
There you go. I was a newspaper reporter, and same thing. I know a little bit about a lot of topics, a lot about very few. But that concept of physicians being the first line of defense in the cancer battle, I'm sure I didn't make that up. I know that's something you've thought about and talked about with your colleagues.
Sure. So family physicians, primary care physicians, we're your first line of defense because if you have a symptom that you're worried about, if you have a family history that you're concerned about, if you need to talk to somebody to get, reasoned medical advice, we're the first person you're going to talk to. So we want to be there. We want to be that first line that says, here's what we think's going on. Here's the initial testing that we think you need. And if we find something, we need to get you to the right specialist who's going to be able to help with that. We're also the ones that talk about screenings, which I think you and I are going to talk about a little bit more here in a moment. But we're the ones that say, hey, we need to make sure that we get you screened ahead of time before you even have symptoms so we can try to catch something as early as possible.
Prevention is the best way to treat cancer.
Absolutely.
And I know, and I've gone through this myself. You even go through it at the eye doctor and the dentist. They want to know your family history, right, and you fill out these long forms. But it's really important. So explain why it's important and what you look for when you take a new patient's family history.
Sure. So when I talk to a new patient and I go through their family history, I try to be pretty thorough. I want to know the current status of all of their first-degree relatives. So first-degree means parents, siblings, children. That's really pretty important. But also some of their second-degree relatives, like their grandparents, their grandchildren, their aunts and uncles. And I try to get a sense of what their medical diagnoses are, not just cancer, but all the major medical diagnoses.
Heart disease.
Exactly. Heart disease, diabetes, that sort of thing. And then if I do see a pattern that says, oh, you've had a number of family members who've had a certain kind of cancer, especially maybe at an earlier age or a more aggressive form, we might start thinking, could there be a hereditary syndrome? One of these genetic factors that we know leads to an increased propensity to cancer. Some of your other podcaster guests may have talked about Lynch syndrome or the BRCA genes. And that's the kind of thing, the kind of pattern we're trying to pick up on. But even if it's not one of these known heritable, it's this gene that's causing it, sometimes just having that family history that says, oh, you had a relative who's one of your first-degree relatives who was diagnosed at a young age with a certain kind of cancer, that's going to lead me to be more inclined to screen you a little bit sooner, a little bit more often than I would otherwise.
Meaning, and with certain things, mammograms you could start at an earlier age, colonoscopies you could start at an earlier age,
exactly,
or even more often.
Exactly.
Yeah, and I'm guessing you've found examples of that in your patients where the family history has indicated that.
That's right. So sometimes I'll have a patient who says, oh, my father was diagnosed with colon cancer in his early 40s. And I say, oh, that's a pretty young age to have that. Maybe we should be thinking about screening you a little bit earlier. Most patients with average history want to screen for colon cancer in that example at about 45, but maybe we should screen you a lot earlier, maybe about 10 years before your father was diagnosed, if he was diagnosed in his early 40s.
Yes, because with colon cancer, screening is one of the, as opposed to like mammograms and lung cancer screenings, you can prevent cancer by colon cancer by seeing it as in a precancerous polyp.
That's right. That's pretty amazing, actually, because I like to tell patients with a colonoscopy, it's not just a screening test, it's also a treatment. Because if we cut out these polyps that are precancerous before they become cancer, well, then at least that polyp can't grow into more cancer.
That's an amazing thing, that you can cut out a precancerous polyp and the person will never, the person who could have gotten cancer and possibly had a bad outcome, they're not going to get it.
That's right.
Wow. Well, let's talk about, I did read on your resume, your bio, you are an expert in vaccines. And one of the things we've talked about a lot on the podcast is the HPV vaccine and how that can prevent cancer. And I get a sense that not everyone knows about it.
Yeah.
So give me an idea of what you tell patients and what you hear from patients about this.
So thank you for giving me the opportunity. I am a big proponent of vaccines. The human papillomavirus, HPV, is an extremely common virus. It's ubiquitous. We pretty much all get exposed to it. There are certain strains of it that aren't a big deal, that cause warts, on your hands and feet. There are certain strains of it that can lead to cancer, okay?
Several different types,
Several
right?
different types, right. The big one that we probably think about most often is cervical cancer, which historically has been a pretty bad cancer for women to get. Other kinds of cancer would be cancers of the head and neck, because that's same virus can get up and cause things in the throat and that sort of thing. So we have a vaccine that prevents this virus from causing cancer. We have a vaccine against cancer.
Yeah.
I find that to be pretty amazing, okay? It works the best the earlier that it's given, so before you're ever exposed to it, which is actually why we recommend giving this vaccine to children. You can do it as early as age 9. In fact, I have 4 daughters myself, and I've gotten them all vaccinated against HPV starting at age 9. It is a fairly simple vaccination, just goes in the arm like any other shot. It's a couple of doses, 2 if you're pretty young. If you're a little bit older, it might take 3 doses. Once you get those, you're done forever. If you get it before you're exposed, it's very effective at preventing those common high-risk strains that can cause the cervical cancer and the head and neck cancer. So I recommend it for all of my patients. The official recommendation is that everybody ages 9 to 26 should have this. They haven't had it before. Even if you're older than that, even if you're 27 all the way up to age 45, you could consider getting it after a discussion with your doctor if it would be benefited for you.
That's been recent years that they've upped the age.
That's right.
Above, because someone has said that in the podcast. So up to 45, and there's a lot of people in that 25 to 45 range that it just wasn't around. The vaccine wasn't there when they were younger.
That's right.
Wow. What do you hear from patients? Do they know about it? Or they do they want to take it, or is there some resistance?
So, since I am starting the discussion with younger kids, a lot of the talks I have are actually with the parents.
Right.
Many of them have heard of the HPV vaccine. Many of my patients or many of my parents are happily willing to give their children the vaccine. It's just another shot, just like their tetanus shot or their meningitis shot, so we just go ahead and do that. Older patients that I talk with a lot of them are like, oh, that's a good idea. Maybe I should do that. Especially my older female patients are like, oh, that's the thing we do the pap smears for, right? That's the cervical cancer. It's like, that's right. So if we do this HPV vaccine, if we were able to eradicate HPV, not that we're going to, but if we could, we wouldn't even need to do pap smears anymore.
Right.
So.
Wow. Because I know, I know for myself, I've been putting off getting the shingles vaccine for a while. I'm going to get it, but it's just like, it's just life's busy, and it's another thing, but I'm going to get it because they're important.
I strongly recommend it. People don't typically die of shingles,
right.
But it is terribly painful if you get that.
Yes.
It is much better to get the vaccine than to get a case of shingles.
Now, the most common type of cancer is skin cancer. And again, you may be the first person to see this as you examine someone. So what do you look for, and what have you seen? I'm guessing you've seen a lot of suspicious things that you have concerns about.
I absolutely have. So when patients have, skin lesions and they're growing or they're bleeding or they're painful, I want to take a look at that. Sometimes I can look at something and think, oh, you know what, I'm glad you brought that to my attention, but that's actually not a concern. That's something that's totally benign just by looking at it. But there's other times I think, ooh, That's something that I'm a little bit more worried about. We should get a biopsy. We should have you see a dermatologist. We should make sure that we get this taken care of. When I'm counseling patients about what do you look for, like in a lesion, in a mole, right? I tell them, especially with moles, because that might imply melanoma, which is the worst kind of skin cancer. Look for the A, B, C, D, E's.
Right,
Okay?
okay.
You may have heard of this one, right?
Yes, we have.
So if it's asymmetric, that's bad. If you can't see the borders very well, that's bad. If the color's variable, like red on one side, brown on the other, that's bad. If the diameter is bigger than a pencil eraser, about 6 millimeters, that's bad. And if it's evolving, so getting bigger, changing one of these other aspects, that's bad too. Those are all the things that I want to take a close look at, either myself or get you into one of our dermatology colleagues.
So you've become an expert on looking at things and sort of having a sense. And I'm guessing you were going to, if you're not quite sure, you're going to err on the side of caution and recommend seeing a dermatologist?
That's right. Or I potentially might biopsy it myself. Family medicine doctors can do that. What's really fortunate here in the OSU system is our ability to even do an e-consult. I can take a picture of your lesion.
Yes,
I
yeah.
can send to the dermatologist, get an answer back pretty quickly, and they can tell me, this is nothing to worry about, or no, we need to take a closer look at that. We might need a biopsy.
Okay, and I'm guessing you've seen this a lot.
Quite a few times, yeah.
That patients do get diagnosed with skin cancer, and even your patients do get diagnosed with skin cancer and melanoma.
They do, absolutely.
It's the most common form of cancer.
Yeah. I actually have personal experience with that. My mother's been diagnosed with melanoma 3 times.
Wow.
So she's doing fine now, thank God.
Okay.
She's got a regular skin cancer
Did she come to you and say, take a look at this?
No, this is actually before I even became a doctor.
Okay.
But I am I'm cautious about my own health.
Yeah.
I've never had a skin lesion that I was worried about, but I see a dermatologist every single year just to get a skin cancer screening.
And I'm guessing you also recommend to your patients about proper sun safety.
Absolutely.
Of, putting on sunblock and things like that, and particularly with their babies and young children.
Absolutely. I tell the parents of my young children, I never want your kid to get a sunburn.
Yeah,
ever.
Exactly.
Okay? If avoid the sun during those peak hours, especially in the summertime. If you have to go out, cover up, right? Lots of clothing, lots of broad hats, and if your skin's going to be exposed, those broad spectrum sunblocks are pretty important.
So one of the most common forms of cancer for women is breast cancer, and you did mention briefly before the BRCA genetic mutation, the breast cancer mutation. Mm-hmm. But talk about breast cancer and mammograms and what you look for to be suspicious, or tell women about self-exams and mammograms and just what you advise your female patients.
Yeah, so breast cancer's pretty well known. I think most women are conscientious of the fact that they are at risk for breast cancer. 1 in 8 women will get breast cancer at some point in their life. That's a lot, 12.5%. That's a lot of people. And so I routinely recommend breast cancer screening for all of my female patients. I have to be honest with them, there are differing guidelines on exactly when to start and how often. I think we can come to some consensus that about age 40 for an otherwise healthy patient is a good time to start doing breast cancer screening.
Sooner if they have a family history.
Exactly. I do share my own personal bias, okay? I had a sister who was diagnosed at age 29 with a very aggressive form of breast cancer, so I tend to want to screen early and often. Mammograms are a test that we've been doing for decades that have shown to decrease breast cancer deaths quite a bit, so I am a strong advocate for my patients that you should probably just go ahead and do this, okay?
I get the sense that most women want to do the mammogram, that their knowledge of breast cancer and how devastating it can be leads them to say, I'm not taking any chances with my own health.
That's right, because it's so common. Most women will know a friend, a family member, someone who had breast cancer, and they realize, you know what, I should be conscientious too. I need to get that mammogram.
And then the flip side for men is prostate cancer, which is it as common as breast cancer or close to it?
It is very common.
Yeah.
Many men will get prostate cancer at some point in their life. Screening for prostate cancer, to be upfront, is a bit more controversial. We used to recommend prostate cancer screening for every man, regardless of any sort of history. Just do it every year. Nowadays, we try to be a little bit more selective in our prostate cancer screening. The official guidelines that I follow from the American Urological Association say that for men, of otherwise normal risk between the ages of 55 and 69, they should have a discussion with their primary care doctor, so with me, on whether they want to go ahead and screen for prostate cancer or not. We typically do that with a blood test. Okay, you may have heard of the prostate-specific antigen, or PSA test. It's very simple. It's just a blood test. It comes back with a number. Based off that, we might give them some reassurance that it's in a normal range, or a little bit of caution that if it's starting to get a bit higher. And if it does, we might need to repeat it. We might need to have them see one of our urology colleagues and lead down that path.
So you say at the age of 55, but before 55, don't you get a blood test as part of your regular yearly primary care exam?
It can be, especially with the family history, especially if you're following some of the older guidelines, you might consider doing that.
So, yeah, I'm just trying to remember it seems like every year for a long time I get my yearly exam and they do a blood test, and it seems like they've been doing the PSA test well before I was 55.
Yeah, and to be honest, for some men we definitely do that. And in previous decades it was as common as mammograms. We would do it all the time. Like I said, we've pulled back a little bit from maybe a lot from doing it as often as we did before. And to be honest, there are a lot of men who do opt out of prostate cancer screening altogether.
Even if they're already getting a blood test for cholesterol and other things?
Sometimes. Partly because they might not necessarily want to walk down the path of leading towards prostate cancer diagnosis. Don't get me wrong, prostate cancer is incredibly common. Many men will get prostate cancer. But depending on other factors, sometimes it's a more indolent cancer that might take a lot longer to cause a significant problem. So there is some thought, and I will be happy to hear contrary opinions, that some men are going to be more likely to die with their prostate cancer than of their prostate cancer. And
we've talked about that on the podcast, but and hopefully those men are getting active surveillance from a urologist, prostate cancer doctor who's screening, and when it gets to a certain point says, now we have to do something.
Right.
So, yeah. We're going to take a quick break, and when we come back, we're going to hear some more types of cancers and how you can screen for them and treat them.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with Matt Farrell, and you gave a great update and review of several types of cancer, but unfortunately there's several more types of cancer that are out there and pretty common, colorectal cancer being one of them. And you mentioned briefly a little bit about that, but it is amazing that you can prevent colorectal cancer before it becomes cancer. So talk about when people should get screened and what the actual screening involves.
Yeah. So for someone who is at otherwise completely normal risk, we recommend starting colon cancer screening at age 45.
Yeah, it just went down from 50,
50,
right?
that's right.
Yeah.
It used to be 50, then we dropped it down into the mid-40s. So at 45 is a good time to start doing colorectal cancer screening. There are a few different tests that you can do. The two that I probably talk to my patients about most often is a colonoscopy, right? That's the gold standard. We mentioned that before. Now, I will grant you, and all my patients would agree, nobody wants to have a colonoscopy. Yeah. It's not a very pleasant thing to think about. But as I said, it can prevent cancers from happening, which is amazing. And it's not even really so much the procedure, it's the preparation that people have a little bit of complaints about.
I've gone through it a couple times.
Yeah. If it is completely normal, right, you can actually go 10 years before you need another one. The other test that sometimes we'll offer is a test that checks the stool for both the blood in the stool and also the DNA changes that can happen in cancerous cells. That's a test that's shipped to a patient's house. They just do it in their own home, which is kind of nice. If it comes back positive, doesn't mean you necessarily have cancer. Just means that we would want to move on to the colonoscopy to see why it was a positive. But if it's negative, it's pretty reassuring, in which case we can just do another one in about 3 years. Okay? There are other ways to screen too, but those are probably the two most common that we do for colon cancer screening.
Do you find people want to take the test? Do you find any resistance, particularly as you have the colonoscopies?
Most patients are willing to do some sort of colon cancer screening. If they're not willing to jump straight to the colonoscopy, they might take the stool test as an alternative or one of these other tests. But I usually can get them to do something, okay? Because remember, some test is better than no test.
And I am not a doctor, but I will highly recommend the colonoscopy because when I had one, they did detect a precancerous polyp and removed it. And I would have had colon cancer in X amount of years, and now I won't. And that's amazing.
Right.
So,
and even if you're the unlucky one and there's already cancer there, maybe they found it at a much earlier stage.
Because it's pretty slow growing.
That's right.
So, yes, exactly.
Yeah, I give the example of my brother-in-law, okay? He was 52 when he got his first colonoscopy. This is back when they were recommending it 50. And my sister had been poking him, you should get this, you should get this. And I'm very thankful that he didn't wait until he was 53 because he had a large tumor, low down in his colon, but they were able to resect it. It's been alive for 20 years since.
20 years, wow.
Yeah, 18 at this point.
Wow, well, knock on wood. So there you go. There's two examples of why it's so important. And I know in recent years, lung cancer screenings have become more common and recommended, and you'll tell me the exact one is for people who've smoked a certain amount of cigarettes for a certain amount of years.
That's right.
And who are higher risk.
That's right. So this is a great screening test for the appropriate patient. So this is for patients who have smoked at least 20 pack years. So, a pack a day for 20 years, 2 packs a day for 10 years. If it adds up to that 20 pack year history between the ages of 50 and 80, or if they have that pack year history and they've quit within the last 15 years.
Okay, 15.
Yeah.
Okay.
So if they're a recent non-smoker who recently did smoke or someone who is actively smoking with that history, they should get one of these low-dose CAT scans, these CT scans of the chest to look for any abnormal, findings, in which case that might lead to a diagnosis of lung cancer at hopefully an early stage when it might be surgically resectable.
Yeah, because the advances in surgery and immunotherapy have tremendously improved the outcome for lung cancer that's detected in the earlier stages.
In the earlier stages,
Yeah,
because
still
historically,
early is key.
Historically, if you just wait till symptoms, lung cancer doesn't show up until pretty late, and by then it's advanced, it's spread, it's very hard to treat, very hard to cure. So if we can catch it early, that's the whole point. And we've got some great doctors here at the James who can do a lot of good things to get rid of that cancer at an early stage.
And do you find people know about this lung cancer screening, or because it is fairly new?
It is new. I will tell you that a lot of patients weren't aware before I've told them that, hey, by the way, you qualify for this lung cancer screening. But once I tell them, a lot of patients are pretty on board with going ahead and doing it because they realize that their smoking history puts them at that higher risk.
Yeah, it's interesting because people who smoke, it's so habit forming and hard to quit, and they know they're risking lung cancer. So it's almost, I would hope it would be like, this is a way to, protect myself.
Yeah, mitigate some of that.
Because they know it's bad for them, but it's so hard to quit.
Because nicotine is really, really addictive.
Yeah, it definitely. So now, some of these cancers, the symptoms are pretty obvious: a lump in the breast, a big mole out of control. But there's some cancers, particularly like internal organs, that the symptoms are either none or could be 50 different things. So how do you, when someone has just a pain or some discomfort, what do you do or ask them or test to determine what it is and if it could be cancer?
Well, first of all, I'll tell your listeners that if you have a symptom you're worried about, go talk to your family doctor, okay? The things that we look for that raise a few red flags that I think, ooh, this sounds like it might be something a little bit worse, would be things like losing weight when you weren't trying to. That's a bad one, okay? Fevers at night for no other reason. That's been going on for a while. Sweats at night. General fatigue can be caused by so many things, but it makes me start to look for, maybe I should look at this and that. And then, of course, we take the full history. We want to know your family history of cancer. We want to know your smoking status. We want to know the things that might worry us. But, of course, if you have a symptom, don't ignore it, right? You have the lump that you mentioned. If you have blood in your stool, if you've coughed up any blood, all of that, which I would hope would be obvious, you should go to your doctor about that.
Or isn't even like a persistent cough that doesn't go away could be something with the lungs.
Exactly. Yeah. It might be nothing at all.
Right.
This may be that you had a virus a couple of months ago and it's just lingered around, okay? But we won't know that until we do a little bit of testing.
And you have at your available to you at your facility where you see patients, many of the testing options, but you're part of a giant university cancer and non-cancer medical center. So you have experts in any kind of medical issue that can arise anywhere to any person.
Yeah, I'm extremely fortunate to be part of the Ohio State University system. We've got a lot of great specialists, and not just for cancer. I mean, we've got a lot of great specialists for a lot of different things.
Center.
So it's very helpful. I practice at the Outpatient Care New Albany building. Even right there, we have so many services in that same building between imaging, specialists. It's pretty nice, actually.
Yeah, that concept of the outpatient big campuses that have sprung up Ohio State, like surrounding the city, has really given more people access to experts like you and others.
That's right. Yeah, we've got our New Albany location, our Dublin location. Pretty soon we'll have our Powell location. So we've been making great strides in that.
So obviously and hopefully in the earliest stages, many of your patients have been diagnosed with cancer. What is the role of the primary care physician once one of your patients has been diagnosed?
That's right. So we're often the initial quarterback trying to get the patient to the appropriate specialist. Like I said, we have a lot of great doctors here in the OSU system that we can get these specialists. And then we're kind of the coordinator after that, right? What did Dr. So-and-so say to you? Did you understand that? Did you talk to Dr. Other so-and-so about this? The other thing I like to really address with my patients as their family doctor after they've started the cancer treatments, whether it be the surgery, the chemo, the radiation, whatever it is how are they doing, as a person, right? How are you feeling about this? What's your emotional status? What's your physical status? What symptoms are you having? And so that's the kind of thing that I want to make sure is being addressed at the same time. All the doctors want to take care of the patients, but sometimes it's that holistic approach that the family doctor has that can help a lot. The other side, the potentially sadder side, if you think about it, is towards, a patient who might have a more terminal diagnosis, right. Someone who's reached towards the end of their life. We want to make sure that the goals of their care are being addressed, right? Do we really want to focus on quantity of life? Maybe we do. Or do we want to focus on quality of life? Maybe that's more important. What's the patient's goal? And I want to make sure that that is being addressed.
And I just thought of this, that knock on wood, so many patients are cured and go into remission, and you may see them for another 30, 40 years, but there still could be issues either related to their cancer or their treatment. So that's another thing you look for and try to be on top of.
That's right. Sometimes they could have some lingering potential complication from the treatment of the initial cancer that I need to be aware of. Maybe that initial cancer puts them at higher risk for other cancers we need to be thinking about. Right. Maybe we need to worry about a recurrence of that original cancer. Follow whatever screening the initial provider has given them after that period of, however many years they've seen them after their initial cancer treatment and hopefully curative treatment.
Well, that was a great overview and reinforced my original supposition that primary care doctors save lives and are the first line of defense in cancer. And you just showed us exactly how and why you do that. And I always like to ask my guests, what made you specialize in family medicine, being a primary care physician? What led you down this path?
So I have to give credit where credit is due. I was inspired by my own family physician. I like to say that he took care of me since before I was born.
Yeah, it's true.
And for many years until he retired. So I was kind of a sickly kid, so I saw him a lot. And so that helped me get some sense of what I wanted to go into when I went to medical school. I tried on the various specialties and realized that, I really like taking care of the whole family, right? All ages, from newborns all the way through the elderly. In practice, I love seeing whole families. Just today, I saw a grandmother who was there with her daughter, who's also my patient, with her daughter-in-law, who's also my patient. Her husband is my patient. Their kids are my patients. They're getting to the age they might have their own kids. I might even have 4 generations there.
Wow, 4 generations of patients. So it sounds like that relationship with your ongoing relationship with your patients over the course of their entire lives is a motivating factor for you.
Yes, and I love seeing patients who, when they're generally fairly healthy, and trying to keep them healthy.
Yeah.
I'm a big fan of preventative medicine, whether it be cancer screenings or vaccinations, or even just making sure their cardiovascular risk has been assessed, their cholesterol, their blood pressure, those sorts of things. And I like doing it all.
Okay. Well, thank you. That was a great overview, and I'm going to repeat myself, but primary care physician save lives. So keep up the great work.
Thank you, Steve.
This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.